when a patient enters into the emergency room, what we're looking for is how much deficit do they have. This goes to movement on, movement of arms and legs, how strong they can move them, because sometimes somebody can move them, but they can't move them up against off the bed, or they can move them, they can flicker them, but they can't actually do anything more than that. Other times patients are perfectly strong, but then they can't hold it up. So these are all different levels of strength. You have the same thing with sensation. You have coordination that we use. We have speech, understanding of speech, there are people who can comprehend, and you can ask them to do things and they can do those things, but then when you ask them to talk, they go, you were in that category where, and then it was, as the stroke progressed, you became less and less able to follow commands, which means that we're progressing through the territory, meaning that that stroke is getting a little bigger. And that's what we don't like. So it helps us to understand the severity and where we think the blockage is going to be. So it's kind of by knowing what side's affected, by knowing how densely affected that side is, by knowing how many other variables are, speech, vision, face, tongue, throat, all of that sort of stuff, we can start to localize in the brain how big of a territory we're talking about. And how does that help us? Well, it helps us because treatment kind of corresponds with that. So if you're a low stroke score, but you definitely have a stroke score, TPA may be more of maybe a better option for you. Or it may be in the back of the brain, because until the back of the brain completely goes out, and you can imagine if this is Grand Central Station, the organism has every desire to keep that open until the very end. So you can have a very low stroke score because it's all back here until the very end of that stroke. That woman that I just described to you has some stuttering through the ER, so people did not pick up on the fact when she first comes in and she's throwing up that she was actually having a stroke. At the very end, when she's no longer responsive and needs to be intubated, everybody kind of picked up on the fact that she was having a stroke. The cortex is more one side of the body type of movement. So what we have found is that when someone has a higher stroke score, kind of in the teens, that what happens is that we know they're probably coming to this lab, because it means that the blockage is more proximal and it's affecting a larger part of the territory. When we get up into the 20s and 30s, those are very significant strokes, meaning the likelihood of living beyond that stroke, if we don't change the outcome, is that the patient will probably die. So this is how, when we look at that stroke score, this is what we're doing. We're kind of guesstimating, without even imaging. We can just get from the clinical exam, we can figure out kind of where we're going to need to go for treatment and who do we need to be calling in. So if I see somebody with a super high stroke score, I'm pretty sure it's ischemic because they're not saying they're having a headache. I'm already calling my team in before the CT and CTA are being performed, because everybody's getting ready, because everybody knows we're headed upstairs. So those are the reasons that we use that. And then on the backside, we use it to compare. So we know what somebody came in like, and we use it to say, well, they were this when they came in and now they're this. And we know we've either improved or we've gotten worse. So those are ways. So if you came in at a 4, we don't want to see you starting to get to an 8 or a 10. We want to see you going from a 4 to a 3 to a 2 to a 1, or staying at that 4. We don't want anything changing. So we use it as a mechanism also to be very consistent in our clinical assessment of a patient once they're here.